physician should know. So, Dr. Vivek Gupta is a very well-known personality, and you can see him around on different public social platform. He is a very popular person. So he is MD, DM with number of fellowships, working with Apollo Hospital. And apart from the regular activities, I mean the work of intervention in cardiology, the most important thing that I would like to add is that he has got some philanthropic activities also, particularly.
Okay, but of course, we're sitting in front of my teachers. It's always a pleasure to talk with all the colleagues and friends and seniors and juniors from the KGMC, KJMC. Still, whenever I call that I'm from King George, all over the world, they all know when I speak in Kolkata, when I speak in major financial things. So he joined medicine initially and then joined pharmacology. So after 1 year, Vivek Gupta, he said he was always asking why he's going to the paraclinical, continuing the clinical. So there was certain special reasons. He said he was more interested in research, but he never repented. He said if he was done MD medicine, his batchmate never got any post in KGMC. He had to settle down in KGMC. That is why he went to pharmacology. Otherwise, I would have gone somewhere else and I would not have been in KGMC. So this is all destiny. So coming to the topic, intervention, I will be talking a little more general rather than being specific guidelines. We all know it is only a process of knowing each other and process of just a small memories coming back, especially of cardiology, interventional cardiology. I went to France after doing my DA, and I worked for a few months in Rizikiji as a pool officer. Dr. Nukul Sinha was the chief at that time. And then after coming back from France, I joined immediately Apollo Hospital. I always say if I had put up my own cath lab at that time, Manoj would have been with me. I would have been in different form. But I don't depend. Apollo was a nice place to work and still working there. So let me start with the 5 invitation. That was a little about my Manoj is my batchmate. And so is Samir Gupta is immediate junior. Samir Gupta father and my father worked together for a long time in pharmacology. So complex angioplasty, multi-vessel stent, I will not bore you. I will go very quickly and then come back to the place. So there are, when Manoj told me that you speak about something recent advances, I wanted to speak on TAVI only, because I worked in France with Alain Tribier, who is the father of TAVI. He said, make it generalized for the physicians. So we all know that just to recall, in 1998 when I came back from France, angioplasty was very little known to people, until general public. So I gave an interview in Times of India at that time, in Apollo, and they published with almost half a page photograph of mine regarding angioplasty stenting, because public did not know. Now everybody, even Extrapolar knows stent laga dijiye. So it's that difference, 98 to 2024, everybody knows stenting, everybody knows bypass surgery. It's good that people are aware now. So I'll talk about complex angioplasty, multi-vessel stent. I'll talk about angioplasty in high-risk setting, primary angioplasty, thrombosection, which we are doing. A big setup is required, angioplasty in calcified angulated coronary artery. I'll talk about TAVI, which is transcatheter aortic valve implantation, aortic stenosis, and mitral clip procedure. I'll just touch upon. Of course, there are a few slides of atrial septal defect closure, which can be done non-surgically. I'll talk about the vascular lithotripsy. And lastly, I will talk about my small experience with Ambani's wedding, which was a great experience for me itself. The historical perspective, we all know angioplasty, the opening the clogged arteries. This is a man whom we should salute. If he was alive today, he would have been 90s. Andreas Gunzig did the first angioplasty. He was a fellow working in Germany. At the same time, Adolf Bashman did it. He was immediately shifted from Germany. Americans were very powerful. They made a cath lab in his name, and then he had such a high salary that from Germany he went to US and he had a chartered plane, and he died in one of the plane crashes. So he was one of the worst fellows who started with the first coronary angioplasty. First coronary, this was the wires, simple gradients which were using, because doing it for the first time, it was done 1977. This is, I think it's wrong, it's not Zurich, it was actually Germany, a German fellow. It is not Switzerland, it doesn't matter. But Zurich, of course, the first angiostenting was done in 1987 by Ulrich Sigwart in Lausanne, in Switzerland. So these two landmark things happened, and then of course at that time there was only bare metal stent, we all know. bare metal stents were having restenosis rate of 20 to 25%, which was quite significant. And therefore, they worked out for the drug-eluting stents, first generation, then second generation, then third generation. Now we have nickel to cobalt chromium with a very thin skirt, very less instant stenosis, only 2% to 3%. I have never seen more than that, and very less percentage of subacute thrombosis, which was a major concern while doing such angioplasty stenting, because you open a 95% blockage and within 24 hours you end up with a subacute thrombosis of 100%, which can be fatal. Was a big, although now still it is about two. I will always tell to my patient 2 out of 500 or 1 out of 500. Very minuscule, but if you are very cautious in anticoagulant regime and you do give some GP2B receptor antagonist, then this percentage I have never seen in my personal patient, any patient of subacute thrombosis, which is a big nightmare for any interventional cardiologist. So for some time absorbable stents came up, but they did not show life, and now we are not doing. I will start with few cases, a few videos of my complex angioplasty stenting, which we do on a regular basis. The important thing which I would like to highlight is that one of the rickshaw puller, he came in cardiac shock. He was passing through the Apollo hospital. He was in cardiac shock. He was immediately ventilated. He was shifted to the cath lab. I was on call, but my phone was not reachable. So they called somebody else, and for some reasons, the other cardiologist, I don't have any reason not to say about that. He said he could be brain dead. So sometimes you have to take a chance. He said we don't know about the neurological status. He had a CPR for quite a few minutes, and therefore there is no point to do angioplasty stenting or taking up ventilation. They called me another person, CMO, he called me again, and I was sitting in OPD. I went up, I said we should do it. I did not know that it had been already refused. But this patient actually, on intra-aortic balloon pump, we put a thrombosuction device, we removed the catheter, and finally he's living. It's almost 4 years. So I would always say that you have to be a little. I will just show a small portion of this video.
Already DAB Cardiology now going to be shifted to Saudi. Our emergency team who has done a big job.
I'm Dr. Vivek Gupta. So I think I will not give you details about this. This patient had acute LVL MI with ST elevated within 4 hours, not thrombolized, ventilator, CPR, almost was imposed with the ventilator effect. We did not know, but he came out after 2 days. Successful angioplasty ejection fraction was now is about 50%. So sometimes these acute MI patients, they are really well. 39-year-old, recently done by 100% already with thrombus rupture with direct stent. I always tell my interventional cardiologists I do such videos sometime to teach my. This is actually live. I did a live Facebook live angioplasty with this patient, and so showing all the steps of thrombosuction and direct stenting, no balloon inflation. Because when the thrombus is the main reason for this, then there is no point to do
Professor Dr.
videos.
डॉक्टर दिल्ली अपोलो हॉस्पिटल से 8 जुलाई पेशेंट है.
Sorry, it's not. Can somebody help me so that I can show only last portion of each videos? Okay, doesn't matter. In thrombosuction, I show.
Professor Dr. Gupta, Diab Apollo Hospital.
If somebody can come here, if I could just that would be easy, because how to go the last portion.
8 July patient है 39-year-old and acute MI. Acute MI in young patient is getting more and more common, and I would like to show you some steps we have done. And this is in Apollo Hospital, Delhi on 8th July evening at 7 p.m.
I think there's no harm in seeing that video at least after course.
So we have already done angiography, and which has shown angiography has shown 100% mid-LV blockage after diagonal one. Patient is hemodynamically stable, and although we have taken a left side groin arterial sleeve, taken a double pump nearing through then I can really test it. It's short because दोनों शब्द में देखो हाथ से देखो 100% आखिरी ब्लॉक है वहाँ पे रेडी में. Now with the help of this देखो we are already having the guiding catheter there और हम उसमें
हाथ नीचे लीजिए.
the guiding catheter is already hooked and now we will cross. You can have देखो हाथ से देखो
अगर छोटा करे तो हो जाएगा आगे. सॉरी, हाँ अब हो जाएगा. Okay, then I can now. Yes. Okay. You can show the last portion of this. This is a thrombus. You can see removed. Why?
दिखाया ये क्लॉट है. वाइट वाइट है ये निकाला हमने.
देखो बेटा. So I want to tell that just put the wire, do thrombosuction, no inflation, and no balloon, and then put stent. Final result is perfectly alright. You can see that it is flowing very well. We have to do another step. So this is one of the cases. And where we do angioplasties, coming on to thrombosuction, many cases, diagonal occlusion with balloon pump support, thrombosuction, angioplasty high risk with thrombosuction with a cardiogenic shock patient with a balloon pump, angulated right coronary artery with calcium. Sometimes you don't need the rotablator, sometimes you can do without it. So this was a small overview of the complex angioplasties. Coming to TAVI, which is a talk of the day, or other talk of the year or talk of the decade. So transcatheter aortic valve implantation, which is a very important technology devised by Alain Cribier of France. My mentor, I worked with him in 96 to 97, 98. We recently lost him, unfortunately. Sometimes we are guided by guidelines. He had ejection fraction of 45%. I always tell all the colleagues who are in France, if he had AICD, he would have survived. So sometimes the necrotic, of course, material, he was not in Cordon. So I always feel that anybody, just for discussion, guidelines are there to guide you but cannot be imposed. Any patient who has a infarct, who has a necrotic myocardium, who has a possibility of, and who is a VIP, and who has a possibility of having VT or VF, should be given AICD even for even if the holder does not show. My thought process, I have lost few of my friends. Ejection fraction 45, guidelines say 35 के नीचे होता आप लगाइए AICD, नहीं तो मत लगाइए. This is very common. Holter आ रहा है कोई 7 days का आ गया ये ला, उसके अंदर भी कोई आपको VT नहीं देख रहा, but patients are lost. So I think if the patient is actually a VIP, he should get it. He would not have lost Alain Cribier if he was living. To my view, who thought my slides, my stay here in Rouen, a very wonderful stay with this man. And this was the first TAVI from India, done by Alain Cribier in 2011. In 2011, TAVI was not introduced in India. It came about 2013 because the Edwards company in Miami at that time did not approve it. The CGI was taking a long time for the approval. So this was degenerative aortic valve stenosis, which is required in some patients. TAVI is done for the patients with non-surgical changing or other putting another bioprosthetic valve inside the already existing valve, which is alternative to surgical aortic valve replacement. 26% of population above the age of 65 have mild, moderate, or severe stenosis. 2% asymptomatic should require treatment. So number of patients are increasing as the aging population. Because most of the time degenerative aortic valve stenosis, we have a calcific. Mortality otherwise in AVR is 2 to 5% low, but in high-risk patients who have an elderly life and comorbidities, bypass surgery done, the mortality of surgical aortic valve replacement is quite high, and therefore there was a need. And this I would like to tell you about bedside to bedside, because I worked with Alain Cribier. I knew his obsession rather. So the challenge was that why it was challenged? Because you have a coronary occlusion, you can have mitral valve injury, you can have permanent AV block, stroke. It's very near to the coronary artery. Doing for the first time, doing this. Now everybody is doing it, but doesn't matter. But when you start a new technique, new thought process, then it's of course a challenge. But the concept of stented valve aortic stenosis, a balloon expandable stent with high radial force might keep the valve open a valve structure would have to be applied within the stent. This was the hypothesis. A challenging combination of balloon expandable frame and valve structure. First day in 2002 it was done by him for the first time in Rouen, France, and after that it was a mental strength. After that, he said never give up. Perseverance is a key word because it was failed by many things. It is not mentioned here, but I would like to tell you when he was looking for the company, Medtronic and also Edwards completely refused the idea. They said, just forget this, it's impossible, it is technically not possible. This is what Edward was making already surgical aortic valve. So they approached the company, Edward, to sponsor the thought process, to sponsor the new technology evolution, and this was completely refused by them. So then they made a company with Martin Leon in USA. That company developed the idea and also the valve was developed in Israel, and then he did the first case. And the same company, Edwards, finally bought, so it was Caribbean Sapien valve earlier, then changed to Edwards Sapien valve. They finally bought this, now they are the number one seller all over the world. The company which had refused the idea completely to Alan Caribbean is now the number one seller of the same valve, although they did not promote that research or innovation. I'm not doing details, 1985, 87, 94, the development of the valve, 95, 98, 99, the first valve 2000, in the 2000, this was the heart valve that was developed in 2002, the first case was done by Rouen, Finn. Cardiology shock patient, EF of 12%, severe aortic stenosis, bicuspid aortic valve, multiple comorbidities, he was almost to die. Alan Caribbean tells me that he called Martin Leon, should we do this patient or not? Because this was a patient who was supposed to die on the table. Especially for the new technology valve. Martin Leon said, okay, otherwise he's dying, so why don't we should do it? And then he did it, and the patient did for at least 2 years after that. This is the reaction of the valve. This is what Alan Caribbean you can see here, along with Ellen Alchandra and Christopher Prof. And I know this name because I worked there with Alan Caribbean, and this is the man after this published in circulation. And then, of course, the whole biomedical, the cardiology community was thinking about this. 2002 to 2005, there were only transseptal approach which was being done. Then of course moved from Canada, John Webb, Martin Leon, USA, and Caribbean, Patrick Raj, from Netherlands, Antonio Colombo, from Italy, they started doing all this. Kavi enters a new era, PVT was bought by Edwards. 2005, launch of further reasons for success, of course, were too many because this was a valve which was doing well, and now the longevity has been proved beyond doubt. Rigorous scientific evaluation. At the same time, 2019, Sapien 3 and Medtronic Evolute, which is a self-expanding valve, this is a balloon expanding valve. This came up and the hypothesis of TAVI, that FDA approved TAVI for low-risk patients more than 65. Earlier it was only high-risk patient which was approved for TAVI. High-risk patient TAVI, low-risk patient surgical aortic valve. So this was by 2019. A total of more than 2,000 patients, so 20 lakhs patients were there at that time, and 2024, how can we predict the future? So what I need to say, the man who did it for the first time, the father of TAVI, unfortunately is no more. If he had the ICD, he would have been living very big shock to the whole cardiology community and personally to me. Coming on to another part of my presentation, I will say, now I will show you the case, the first case which I did in Rouen, and this was a case, 83-year-old gentleman, first case from India. Not approved in India, so we had to this patient flew from Delhi to Rouen, and it was severe aortic stenosis, valve area 0.7 centimeters square, P gradient of 85, P gradient 65. Ejection fraction was well maintained, and he was referred by a surgeon doctor. I have no hesitation. Ejection was surgical aortic valve replacement at that particular time. So, and of course, VIP patient he never wanted to take up. So we did the MRI, we did, and this patient flew. 18 French femoral sheet was used at that time, now it's 14 French. Utilize a Novaflex sheet at that time. The procedure time doesn't matter. So you can see the valve which is going up, and then it's going down, and then it's the aortic valve, the aortic part, see the coronary, it should be just below the coronary, because if you take it a little up, the precise position is very, very crucial, otherwise you can kill the patient on the table. And it was recently 2022, this was 10th year celebration, and we had a 20th year celebration. I don't have the photographs. I will share, Dr. Narayan knows all these interventional cardiologists. In the audience was Patrick Saraj, Jean Pajade, Jean Marco. They were the audience. About 20 years celebration for this great case. Sometimes they had low blood pressure. and you can't operate them because they're very high risk patient for surgery. So you can always do microclip. This is a new technology with it. IVL is a new technology for breaking the calcium inside the calcified coronary arteries, and this is also being introduced. It's very expensive. This is 4.5. The catheter cost is to 4.5 lakhs. So it cannot be done. That's why we are trying to for last since 2014, when I was invited in one of the programs when the Prime Minister Narendra Modi visited first time in US after becoming Prime Minister. So I had the privilege of sharing the same table with the ambassadors dinner. So I exchanged the card, and after that, so many things. Recently, I met him in the post ceremony, 2024, 4th June, recently. So again, he recalled me and he said, okay, and we met many times in Investor Summit, more than 6-7 times. So I handed over a card to him, as usual. And then, when I received the invitation at my house from the Delhi office, they asked me about Bombay and tickets and then the car. Then there was a person standing right coming out of the boarding gate, but not outside the airport, boarding gate. And they are going all the baggages and everything they are taking care. I would like to say that hospitality is to learn from them. There were more than 6 places, guitar, other place, some big piano or just here, I don't know the names, or Pritam performing with Narayan or these people. So it was such a grand wedding at every place. My children, they recognize a young actress more than me. So she's the wife of Bhushan Kumar's son. तो मैंने पूछा आप क्या एक्टिंग करती हैं? कहते आपने सावी पिक्चर देखी क्या? हमने कहा देखी, बहुत देर बाद होते रहे. But I mean to say that it was full of, and the most important part was there was not a VVIP zone or VIP zone or non-zone. Everybody was same. There was no differentiation. When you go to big wedding, especially minister's wedding, you have a VVIP zone. You can't enter those places where ministers are sitting. But here it wasn't. The most funny thing was this thing. Many people must have seen this video, but I would like to still show this video in the interest of some change in the seriousness of the
Dr. Vivek Gupta, renowned cardiologist.
What happened was that I was talking to Ranbir Kapoor, and I handed over my card during the barat. So, ये वाला जो dubbing करी गई है, that is very interesting.
वर्जिनी रहूंगा सारी उम्र.
रणधीर, मैं बाबा बंगाली, मुंडी हिलाओ अगर परेशान करती है घरवाली.
हाँ बाबा.
ये लो, इस एड्रेस पे तुम्हें मुफ्त का चंदन मिलेगा. तो मुफ्त का चंदन घिस मेरे दंदन, एक बार में अंधेरी से लंदन.
समारोह पूरा प्रधान प्रेसिडेंट इधर और विशेषज्ञ तो lot of media. So this was I wanted to share the very recent, and then this was mystery man networking with Ranbir Kapoor and Nanda Pani when it revealed with Dr. Vivek Gupta from Apollo Hospital. So it's okay, but I think interventional cardiology will further grow. But of course, one caution to this here, they're not young interventional cardiologists. Don't try to overdo the things. I remember one case I would like to tell you of the I was trying to do CT of RCA. We should know when to stop. That's very important. Otherwise, you have many deaths on the balloon inside. So, the most important message which I want to tell to all interventional cardiologists: if you don't want to have serious problems, you should know when to stop. You should know when to stop, and you should be able to foresee the complications. Share आने के बाद आप कुछ नहीं कर सकते. You should know that this patient can be a serious problem later on. In the cath lab, and your life can be wasted, and you will not have, if you do all those things, you will never have any complications during the procedure, and we have to avoid complications. Patient has come for the life, and we cannot take the life of the patient because of the complications, and complications are happening quite often, especially in small places.
What we are going to do, what we have seen and what we are going to see as far as interventional cardiology is concerned. We have moved on from doing TAVR in high-risk individuals to now the low-risk individuals. We have started doing it even in bicuspid valve situations. The first stage is bicuspid, but generally because of the aortic. I would have said that you just stent the ostium and the dissection would not grow. But all right if you refer this patient to the surgeon. So with that, I think I'll hand it over to the organizer, and he will now tell us how to conduct the moderator. We don't have Nursing Verma here. I think he is going to moderate. So Vivek and Dr. Kapoor, why don't you take a chair here? A comments from Dr. Chandra.
So thank you very much, sir, for a leadership talk. Sir, आप कुछ बोल रहे हैं?
Just one thing,
panel discussion since Dr. Narsingh Verma sir is not here because his flight is delayed. I have been bestowed upon this responsibility. So we have already reached 10 p.m. So I will try to keep this panel discussion short, and I will try to should I straight away start anti-disability drug or should I wait? First of all, should I treat diabetes, let the lipids settle down, and even if it is higher, then I should start statin. How should I address triglycerides? So what should be our approach in our clinic? So this is first thing that I wanted to know.
There was this very nice comment by Dr. Gupta. CVD again, so I would go hammer and tongs after this patient. Started on statin, Rosuvastatin maybe 20. Before that, I would wish to see whether he's a hypothyroidist. That's one thing I would wish to know. That is all. Triglycerides of 470 are glycemic control, statin if he is obese, if he is a smoker, aspirin as well. I would avoid gliptin in this patient for the time being. The flavor of the season is gliflozins, I appreciate that, but I would still avoid gliptins. Why am I saying gliflozins? Because gliflozins also have a TG lowering action. We know that. Gliflozins also have an HDL raising action. We know that. So, in a patient as young as 42, aggressive glycemic control, we have so many drugs which at most will normalize blood sugars, will not cause hypoglycemia. So I'll be very aggressive in terms of glycemic control, in terms of lipid control. But if he has hypothyroid, what I practice is start thyroxine and start half the dose of statin, which I would have had in a patient without thyroid.
So that actually brings to the second question which I had in my mind. The same patient I was going to say subclinical hypothyroid, low normal T3, T4 with TSH say 12.5. I had such patient today itself in my clinic. So what will I do with this? Particularly triglyceride was say 350 or so in this patient.
So we have Sir amidst us. He loves thyroid, and I would wish his comments. First of all, subclinical hypothyroidism has a definition of normal T3, normal T4 and no symptoms. Traditionally speaking, less than 10. So obviously, as I said, I would any level, so T3, T4 even if normal, TSH even 6 or 7, not 12, 6 or 7, I would still treat that. And maybe instead of 20, give 10 of Rosuvastatin as in this patient with high levels. So your comments, please.
Just 2 or 3 more indications, non menorrhagia, subclinical, you must treat. Hypertension, you must treat. In fact, I was just remembering the name, Steve-Berg 1968. He did a series of autopsies and found out hypertension with subclinical leads to atherosclerosis, whereas non-hypertension. So thyroid is my passion.
So should we not expect that if we treat diabetes adequately, thyroid adequately, those lipids will come down to normal level and probably we are over-treating patients?
Of 42, that was significant. 40 and 75. 42 was significant number.
Okay. Okay, now I move to, okay, do you want to access? Okay. Now I move to the second part. We were talking about rosuvastatin and atorvastatin. And what I felt that most of us were favoring rosuvastatin, probably it did have better LDL lowering effect. However, the recent meta-analysis that we did have from low-star trial with more than 4,000 patients, that did show that relative risk reduction in cardiovascular event was comparable in both the group, atorvastatin and rosuvastatin, and risk of developing new diabetes was higher in rosuvastatin. So why should not I prefer atorvastatin in diabetic dyslipidemia than rosuvastatin?
No, so this is a cross question. What I would wish to know is what dose of Rozuma causes diabetes. I would wish to know what is the accumulation and also the benefit imparted by rosuvastatin far outweighs the diabetes risk. Far outweighs. Now, let us leave diabetes apart, let us leave lipids apart. Statins reduce the risk of osteoporosis, rosuvastatin more than at all. Post-menopausal diabetes, even I would wish to know, I have no answer, किस डोज पे होता है, कितने साल खाने पे होता है, कब?
और पिटावास्टैटिन के बारे में सर बोल रहे थे, कहीं मैंने सुना था कि improves insulin sensitivity and that's why people do say diabetes में पिटावास्टैटिन देना चाहिए.
So I have never used pitavastatin, I'll be honest, but yes, it increases the adiponectin levels. On a broader note, even glimepiride increases adiponectin levels. So glimepiride का भी action है for sensitizing. But yes, pitavastatin increases adiponectin. That is why it may benefit.
Thank you. So,
sir, I have not used, sir. I have not used. I have used rosuvastatin.
So, are there any questions from house? Vivek Gupta, okay. So we have already crossed 10. So may I request? May I request Sanjay Arora sir to please felicitate Ashok Chandra sir. Abhay Srivastava sir, please felicitate Dr. V.S. Manan sir. We begin the musical evening because we do have many. Ashok Chandra sir, sorry. So before we begin the musical evening, and we do have many
Cardiology and Diabetes Symposium in Lucknow, with the black cover, and
making our evening very musical and eventful. I would like to invite Manoj Srivastava to please give